Hello and welcome to another episode of the NK Active podcast. Today we are joined by Zoe Wilson, a podiatrist based up north, just outside the Lake District, and she owns a clinic called ZW Clinics. And we'll get Zoe to introduce herself shortly, but over the next few months, we're going to be chatting around about all things arthritis, and we've got some professors and guests coming on speaking about different forms of arthritis. But today we're going to have a chat around a particular tool that I personally think is massively underutilized in the management of ankle and midfoot osteoarthritis in particular, and then also things like tibialis posterior tendon dysfunction, which can be related to rheumatoid arthritis. And it's something called the Richie Brace, and it's something that Zoe uses a lot of and has a lot of knowledge about it. So that's what we're going to have a chat about today. But firstly, Zoe, thank you for agreeing to come on and join us. Sort of give us a bit of background about sort of who you are, where'd you come from in Cilla Black kind of style, as it were.
Yeah, absolutely. Thank you so much for having me, Nick. I'm really excited to be on this series of episodes that you're going to be hosting. So essentially, an MSK podiatrist based in the Lake District. My background primarily has been in podiatric surgery. So I did my MSc in pod surgery, and graduated in 2017. And ever since, I've kind of spread my expertise around that area and kind of worked in more advanced practice. So in injection therapy, in Richie Brace therapy, orthotic therapy, shockwave and the like. And I set up a clinic in 2017 and then my second clinic in 2021. I had to remind myself then. So, and I have a multidisciplinary practice. So we have everything from podiatric surgeons, physios, podiatrists, and we're all under one roof. So that's a bit about me.
No, it is. Your clinic's very much like ours. It's based in it's sort of not in the middle of nowhere, but more in the country setting, which is really nice. It's a beautiful clinic. It's yours is nice and airy and spacious, and I definitely need to get up and I've only seen pictures. I need to go up and pay it a visit one day. But you are the opposite end of the country
Yeah,
to
and vice
me.
versa. I keep saying I'm going to come to you, and then, and a lot of what we've done, I've kind of based some of it on what you deliver in your practice. So it's really nice to collaborate in that way.
Thank you. So the Richie Brace is something you're also a big fan of. It's something that I feel people don't know enough about. Our patients and even some of fellow physios or surgeons that we work with, they're like, I haven't even heard of this. But we both know, and we both got patient stories, and you presented one recently where actually it can be game changing for patients, particularly when surgery is not appropriate for them, whether that's medical reasons or whether they just don't want the time up from recovery. I remember we had one patient who didn't want surgery for arthritis because it meant they couldn't sail around the med as much. So they didn't want the time off, and the Ritchie brace allowed them to do that. So, sort of talk to me about your background. How did you get into and discover the Ritchie brace?
So I came across it at a conference, and I do a little bit of work and lecturing for Firefly Orthoses. So the Ritchie brace essentially was founded in California by Dr. Doug Ritchie, who's an orthopedic surgeon in the US. And he kind of treated foot and ankle pathology in terms of pes planus and adult acquired flat foot surgically, and then developed a conservative AFO, which is an ankle foot orthosis. And that's essentially what a Ritchie brace is. There's lots of different types of AFOs. And certainly, if you have a look amongst the literature, it's primarily used in the orthotist field more than in the podiatric field. And I kind of thought, I get these patients in, they've got a flat foot, so a pathological adult acquired flat foot, which has specific features. It's not just flat feet, it's a flat foot. And I was using custom orthotic therapy, getting okay results, and also rehabilitating these patients, recommending footwear. And I kind of thought there's got to be something else that I can offer this patient group that we're going to get them to a point where they can do the activities that they want to do, avoid surgery and injection therapy, which a lot of our patients don't want. And as conservative practitioners, we kind of want them to avoid. And just, I kind of got on and did it. I went to Ireland, I learned how to cast, and then I started to, just from one patient, work out that the casting process was really hard. And it was going to take me a few attempts, and I had to book them in for a really long time to get it perfect. And just that's where it started, really.
Yeah, and there's a couple of things I want to pick up on there. One is slightly off topic, um, but if you're a podiatrist and listening, and you ever get a chance to go and visit Firefly in Sligo, it's a beautiful, beautiful part of Ireland. And I remember when I went over to visit Martin and the rest of the Firefly team, it was an amazing couple of days, amazing couple of days. Lots of Guinness involved, and a couple of great nights out. But it is really fantastic what they're doing over there. And the other point was, before we actually start talking about the Richie Brace properly, was the casting. I started smiling because I remember when I first ever started trying to learn to cast the Richie Brace, I got plaster absolutely everywhere. It's just an absolute mess. And then you think, oh yeah, I've done a really good job. And then you take it off and it kind of looks like the foot, but then you stand up and it just falls back over again. You think, well, actually, that's not a very good cast. It can't stand up on its own. And now it's like, okay, yeah, minimal mess. But it is one of those things that you do need a good cast, otherwise you're going to get a really, well, I'm not say bad products, but you're not going to get the product you want from it, are you? Because I think for me, one of the big, well, the big USP of the Ritchie brace is the way it articulates the hinges on it are what we call anatomically placed. They're placed sort of on the inside and outside ankle bone, as it were. So if you think of it as basically, it's, if you've never seen one, is it's a custom insole with a brace basically attached to it. And I think that's the bit, is that it allows you to walk backwards and forwards and encourages the foot to move up and down, but it's the sort of rolling in and out, the pronation and the supination, that it tries to help restrict, as it were. And if you're suffering with ankle arthritis or midfoot arthritis, you notice that walking on even ground that really the foot doesn't like. And when I went to spent some time sitting in with the podiatry team up at Headley Court, which was the old sort of head military rehab centre. They were using so many Ritchie braces for blast wounds, and seeing people get back to marathon running using a Ritchie brace. And yeah, they're in my eyes, in the right, you give them the right person, they're just absolutely magical for people. Yes, they're not the cheapest things in the world, but if you tell someone, well, actually, if it works for you and it gives someone their life back, that it's worth every single penny. So with you, sort of talk us through your journey, and because you must have, the more you've used the brace, the more you know what to prescribe and when to prescribe it. So if someone was coming to see you and you're and ahhing, okay, is this person orthoses or brace? What's your kind of rationale between choosing one or the other?
I mean, essentially, it boils down to the clinical assessment. So, for example, we get a patient in, they've got features of an adult acquired flat foot. So the first thing I look at is, how is the calcaneus relative to the supporting surface? Is it in a vertical and kind of neutral position? Is it everted or inverted relative to the supporting surface? So that's the first thing. I also look at the kind of transverse plane deformities that we can see in terms of the forefoot abduction. So essentially, when we're looking at these patients, a lot of the classification tools, such as Myosin classification, look at something called tailor head uncoverage, which is something really that you can only see on an AP X-ray. So essentially, that's looking at the articulation of the talus and the navicular and seeing how much is that forefoot abducted relative to that. The other thing, a really simple test in the frontal plane, is looking at too many toes sign. So essentially, we look at the back of the calcaneum and we look at how many toes can we see on the lateral side. Is it 1 or 2, or is it 2 to 5? So, there's some kind of classic features. The medial longitudinal arch profile. The simple tests that we can do, like a supination resistance test, where we place a couple of fingers under the medial arch. How easy is it to create a supinatory moment of force on that medial longitudinal arch? And then I ask the patient to do things. So I'll ask them to actively invert against resistance. Also get them to do a double leg heel raise. Can they do a single limb heel raise support? And again, when we look at the evidence base, if we're seeing these patients in stage 1, 2A and 2B on the Myosin classification, which is a tool that you can Google. So just Google Myosin classification flat foot and you'll see the stages 1 to 4. And really, if we look at the evidence base, it's 67 to 90% successful conservative management of the adult acquired flat foot if we get these patients in and we recognize it early. So for me, it used to be that discussion around sometimes the cost implication is challenging. It is an expensive product, but if you've got such strength, and there's multiple studies that comment on the benefits of conservative management in those 2 stages. I'm quite aggressive from the outset. If I know that's an adult acquired flat foot, even if it's stage 1, I'm going to get them in a brace. And it might be that they're in a brace for a shorter period of time, and there is patients who come out of the brace after 12 to 18 months, they go back into orthoses. So this isn't something that we use for years and years and years in some cases. Sometimes it's for a shorter period.
And I think that's a really valid point, because in those earlier stages, there may be starting to show some early osteoarthritic changes, but not huge amounts are set in. If you're getting sort of late stage where you're getting severe osteoarthritis, then the chances are the brace is going to be more of a long-term feature because you can't undo the osteoarthritis. However, if you look at some of the work now coming out from the osteoarthritis studies and some of the work that Professor Kathy Bowen's involved in, is that, well, actually, we're starting to think, actually, if you catch arthritis early and manage it, can you actually slow down that disease progression? And then we talk about different treatment modalities. We're both big on rehab and strength training. And one of the papers I actually used most in clinic was actually someone's going to be a future guest, Dr. Jill Halstead, whereas she was part of a team where they looked at strength through the middle of your foot and arthritis in the middle of the foot. And in general, they found if you've got arthritis in the middle of your foot, you tend to be weaker. If you make yourself stronger, symptoms tend to be better. And there's more and more research coming out now that muscle strength is an absolute vital tool. But I want to touch on the coming out of the brace, because a lot of people think it is a life sentence, and it's not always that, is it? We got a patient recently a rheumatoid arthritis patient with an irritated tib post, and effectively it took us about 18 months to get her to settle down. But it got to the point where she went on holiday in New York, walked around 30,000 steps in a Richie Brace, and was completely symptom-free. Before that, she's thinking she's going to go down the surgery route. She seemed to be seeing an orthopedic surgeon who was like, yeah, let's do surgery. And she said, let's just try the Richie Brace first. And then I caught up with her 2 years later, and she's now doing all the strength and conditioning. She's still got the brace, but it sits in the cupboard. She didn't need to use it anymore because she caught it in that early stage,
Mm.
treated it appropriately, now rehabbed it, now doesn't need the brace, can do everything just for foot orthosis alone, but the brace is there just in case. So for me, it's always like it's another tool in the toolbox. So for us, sometimes a patient will get brace and orthosis because they can't always wear the brace or don't always want to wear the brace, but it's there when you're going to be going to be needed.
Yeah, I
And
mean, absolutely. Same goes for us. We always give if we're giving the patient a brace, they're always getting at least one pair of orthoses. And that's because when they're wearing the brace, they still need a counterbalancing implement, or we end up with hip and back and goodness knows what else
or they
issues.
or they walk around in circles.
And that will fall over. Yeah,
Yeah.
yeah.
Um,
So
so for you, is there any times you wouldn't use a brace?
yeah, absolutely. I mean, one of the problems, as you know, and as we look at in vast studies that have been published on this condition, that being the adult acquired flat foot, is that it's not caught early enough. We often see these patients too late in our practice. They've been to other professionals who may not have the knowledge base on the condition, and that might be very much our own profession or others. Um, and unfortunately, with it being a progressive problem, that being related to ankle arthritis, subtalar joint arthritis, and midfoot arthritis, the longer that patient is without something to kind of support and what we describe as couple the leg to the foot, um, they can end up with gross midfoot deformity. And the problem is not really the ankle as such. For me, the problem is the midfoot. When we start to get just complete midfoot collapse. And unfortunately, that deems a lot of our orthotic products to be, they're just not usable because of irritation. And often these patients are also progressing to a more rigid deformity. And the other contraindication when we start to get to a rigid deformity is, what are we trying to achieve here if we've got a rigid deformity and not a flexible? It just becomes a very difficult scenario. And having said that, not everybody's a surgical candidate. And I think you've always got to have that discussion with patients around the recovery time of rear foot and flat foot surgery, because it's complete reconstructive surgery. These patients are having a procedure on the calcaneus, so the heel bone, to slide it over to improve the ground reaction force going through the whole limb and the foot and ankle. They're having lateral foot surgery to kind of lengthen the lateral column. They may also be having midfoot fusions and tendon transfers. This is quite major surgery, and really the recovery can be anything up to 18 months. So it's just weighing up whether you've got a flexible or a rigid deformity. I'd say that's the first thing. Having a discussion with the patient. Have they got home support post-surgically? But also having allies in podiatric surgery and orthopedic surgery. And this is where we build our bridges and have that true multidisciplinary kind of circle for that patient to gain opinions and for us to collaborate with each other so that we can come to the best decision for the patient.
Yeah, and the only other time I wouldn't is if someone's got an unstable knee. It's because if you're helping to support the foot, you're possibly going to ask the knee to do a little bit more. And if they haven't got full stability through the knee, you may be thinking a Richie brace may not be the appropriate
Yeah.
tool at this time. And that brings us nicely into, you were talking about when people get severe arthritis, that the Richie brace is always a no-go, but it becomes a little more difficult and it may need a couple of modifications just because, again, irritation throughout the foot. But I think it's when you then still have those patients who are going towards that late stage, but for health reasons can't have surgery. So you still want to try and do something. And that brings us nicely into, like, we know the Richie Brace, there are different types out there. We've spoken a lot about what they call their full articulation hinge brace at the moment. So that is a device that allows your foot to move up and down completely naturally. And the other type of device that can be useful in people with arthritis is what they call their fixed hinge device, especially with the subtalar joint and ankle arthritis patients. So did you want to sort of explain us the differences between those sort of two devices?
Yeah, I mean, quite simply, I kind of look at what range of movement they've got through the ankle in the sagittal plane, so in the up and down. So if we've got a patient who is just and so able to get to 90 degrees, then a fixed hinge for me is the best option, because that's kind of aiding the patient as a splint. And when they're not able to achieve any degree of what we perceive as appropriate function for ankle joint function, it doesn't make sense to use a hinge that then is movable. Now, I also use fixed hinge in cases of foot drop, and again, if you've had a patient who has presented often in the latter stages of the condition, they also develop contracture in the gastrococceleus complex. And so again, 90 degrees, it's not such a bad thing. If 90 degrees with the fixed hinge process is what we can achieve for that patient, that's going to be, miles better than what they're currently trying to function with. We also use what's called the tamarack hinge, which is a dynamic assist. And that's a really interesting method of treating and managing foot drop patients. Because again, if we've got contracture, but we can get them past that 90 degree, then the dynamic hinge will work really well, particularly if it's a flaccid foot drop. So that does work really well. But a fixed hinge has a place. It depends on the presentation, but I think ultimately fixed at 90 degrees for a lot of these patients is, miles ahead of where they've been otherwise.
So we'll come on to sort of the tamarack hinge in a bit, and I'll sort of I've got a sort of a case example of speaking that when I've used it in a couple of patients, not for foot drop, for other things as well. But for you, if you have someone, okay, it's going off topic with regards to arthritis, but it's still Richie Brace related, is that for you as a clinician, if someone comes to you with foot drop, when would you use a tamarack hinge, which is that basically it's a sprung loaded hinge. So you push the brace down and it pings up. So that means when your foot swings in the air, the brace is effectively pulling your foot up to stop it from catching on the floor and tripping over. So when would you use a tamarack hinge versus a fixed hinge?
So I'd use a tamarack hinge if I'm able to get the patient past that 90 degree. So when I say 90 degree, I mean relative to the foot and the lower part of the leg. So that may be essentially when the knee is partially bent, as it would be through the swing phase. If I'm able to get them just beyond 90 degrees, I'll use a tamarack. And if I'm not, then I'll use a fixed. And it also depends on stability. But ultimately for me, it boils down to what range of movement have we got in the ankle, and what are the reasons necessarily for that. But those are my contraindications. If I cannot get that ankle beyond 90 degrees, the tamarack hinge will fail. Essentially. So that is my rule of thumb between the two. And it also depends on, whether or not we've got ankle deformity as well. So if we're looking for stability and we've got chronic lateral ankle instability, or we've got a palsy of the peroneal nerve, patients like that really require a lot of stability. And in which case I'll use a fixed hinge for those patients as well.
Yeah, no, you're similar to what we tend to say as well, apart from there's one type of patient group who I go against my own rule. And we've seen a couple recently, and it's trauma related cases. So people who have fallen 20, 30 foot off a roof and fractured their heel,
Hmm.
and they haven't quite got the 90 degrees yet, but they're going through the rehab and will have.
Yeah.
And we've used the Richie Brace in those cases to help someone get back walking again. And I remember we had someone in clinic who Richie Brace, and we got them walking up and down just see how they feel, and they come hobbling in, walking out, and I looked round to one of our receptionists and she was nearly crying because she's like, "Oh my God, this person is so happy with like the brace." And then over time, the next stage is then to wean them out to a normal full articulation hinge, and then its plan then is to then remove the brace completely as he goes through his very long and lengthy
Mm.
rehab journey. But that then goes back to the thing of it's not always a tool for life, is it? It changes and adapts as people go on. And again, for me,
Absolutely.
if you get those patients who have had a stroke, the tamarack hinge can be really helpful if the stroke was caught nice and early and they've got the mobility. But you see some people where they haven't unfortunately had the input of the rehab afterwards, or the results of the stroke means they haven't got it and they've got that natural contraction which isn't going to change.
Mm.
And I think that's where the
Mm.
fixed hinge. But then that's also the same as we go to ankle arthritis, where if you physically got a bony block and you can't physically move the ankle past it, at that point, I think you are either looking at a fixed hinge or you're looking at ankle surgery, aren't you? Or replacement, as it were.
I think ultimately, for me, one, it's the range of movement in the ankle and the sagittal plane, but it's also a level of chronicity, isn't it? And it depends at what time does that patient present to you in that clinic? What's the history of the problem? Is this patient going to progress to a point? And that really, when we evaluate how this is going to benefit the patient, you've got to look at all those things. Some of my neurological patients, I often will invite their physio to come to the appointment.
Hmm.
And I've done that on a couple of occasions. And because that person has maybe had a broader overview, for one case, the physio was with the patient every single week. So they understand the levels
Yeah.
of contraction and tone differences that patient goes through based on the day to day. And, having that in the clinic, or again building that network, is really important as to how you select what type of hinge you're going to use. But I think, it is a little bit to do with chronicity for sure.
Yeah, and it is always good if you can, if someone having a long time and they're under care by multiple, is having those people attend the appointment, I think is
Mm.
so helpful, because a lot of the time, if they've got a long-term physio involved in the case, the physio will know the patient so much better and know where they've come from, what's the trajectory, where we're going, and yeah, it just works. It works really well. So if you were to give someone sort of, because there's going to be, you may say there may be a podiatrist listening to this, or maybe a patient. So if we sort of go down the podiatrist route first, is that if you're a podiatrist and listening to this, but you haven't used the Richie Brace, what would your sort of, and you're sort of listening to this and you're thinking, actually, this could be a useful tool. Um, what would sort of your top tips be for these people?
Yeah, I mean, I think if when it was me, I was like, right, what can I find out on YouTube, online? Who knows about this? Who's got a similar story? Oh, it's that person. I've seen them before. I'll contact them and, I'll say, hey, can I bring my patient to you? Or can I send you some videos? Can we talk through the patient's presentation in weight bearing, non weight bearing assessment and dynamic assessment? And we'll go through that together. What's interesting in I was recently speaking at the Royal College of Podiatry conference, and I had 3 podiatrists approach me and say, "Can I bring my patient to you and we can do this together?" And I don't really believe that there's anything more powerful than bringing 2 professionals into a room with the patient as a learning environment. I certainly think casting and stuff, I mean, yeah, there's demonstrations online, so you can go on Firefly's website, and there is a very old video of Martin McGeough talking through the fundamentals of casting, which I've watched about 100 times. So, there is that. But, I think there's benefit in being present and having the professional there. I mean, this was the reason kind of that I developed actually an in-person course for it, because you've got these people eager to learn, wanting to deliver it in the practice, not knowing where to start. And the thing is, you need a good cast. You've got to have a good cast and understand the reasons why you need that cast. So yeah, lots of different ways to go about it, for sure.
Yeah, no, I remember when I was in my early days and speaking to it's just speaking to different colleagues about it to learn more about it, and watching Martin's videos and actually speaking to the Firefly team, because they're just so helpful with it. And with the casting, it's something like, if we got new team members, or you could just buy some plaster of Paris and just practice and practice and practice, because the more you do it, the better you'll get at it. Talking to cast, you've any top tips of any sort of neat little tricks you do to make sure you get a good cast?
Have the patient lying on their front.
Yeah.
Some patients can't lie on their front, so you have to cast with them with a knee rested on the couch and they've got one leg standing. So it can be really challenging, depends on your patient's medical history as to whether or not they can actually lie on the front as well. That really allows you to have the foot and ankle a little bit more like jelly in your hands. If you try and do it any other way, I just don't find that works. So that's the first thing. Establish how much contracture, so equinus contracture, soft tissue, gastrocsilius, Achilles contracture you have prior to doing the cast. And I sometimes will get the patient to do a series of exercises prior to doing the cast, so I can get that ankle freed up a little bit more. So that's a really good method. Also looking at how much motion you have in the forefoot. So is that forefoot fixed in an inverted position, or is it flaccid and mobile? So that would be the description of supinatus by Dr. Doug Ritchie. And really go into it knowing what your challenges are going to be with each individual. For some individuals, it's more to do with neurological tone, and that can be really, really challenging. I think those cases sometimes more so. Also marking up your anatomical landmarks with a board pen, not a permanent marker.
Have you made that mistake before?
Yeah. So that, so I mean, there's a lot of things there that I think about prior to doing the cast. Popping your cast in the microwave afterwards, Nick.
That was something that Martin gave me that tip years ago, and the first time I done it, the team looked at me and was like, what are you doing? Oh yeah, just pop it in the microwave for a minute just to dry it out before, and it does. It sets it really, really quickly, and then I'll fill it with bubble wrap. So then it's just because then as soon as it goes off into the post, it's going to get thrown around and whatnot, and you just want it to get protected and end up. Have you dabbled with scanning yet?
No.
For Rich? No. I haven't either. And when I last spoke to Martin, you just can't get those. you just can't get those anatomical placements done well enough yet.
I think for the level, because of the level at which that product depends on the cast, I'm just not willing to take the chance as to whether or not the technology is there yet. Now, I still do foam impression for orthoses. I don't, I have used scan. I used scan about 5 years ago, and then I decided that I was just going to go back to the impression casting, rightly or wrongly. It takes longer, but I know exactly what that looks like when it leaves my clinic.
Yeah.
I know exactly what I'm sending and what I want to achieve. And I think, rightly or wrongly, I just like the old-fashioned way. And if I'm proven otherwise, perhaps, but
No,
not
no, it's
currently.
whatever works for you. I think I was Martin's first person to start using the structure sense scanner. I've been scanning now for 8 years, and I would say 90% of what we do is with a scanner now. But what I done to test it, I think we got 10 or 15 patients where I done plaster of Paris cast, scanner, gave the patients 2 sets of orthoses. I didn't get the lab to tell me which one was which. They knew, but they didn't tell me. And then I got the patient's feedback, and they couldn't tell the difference. The devices looked the same to me, and at that point, then I've been scanning. But the Richie Brace, because quite often there's more manipulation of the foot and just getting it right, making sure you've got that really tight contact to the arm, and it's fitting the foot like the glove, and
Yeah.
it's so much more a hands-on process than a traditional cast. I'm just like trying to get all that done whilst trying to scan the foot. Yeah, I just haven't quite mastered the way yet of
The
doing
other
that
thing
plaster.
is one of the when we do the cast, as you know, we want to really plan to flex that first ray in order
Yeah,
to achieve that medial
yeah,
longitudinal arch profile. And you know as well as I do that that isn't possible without being able to do that. And often times part of the compensatory mechanism of a flexible acquired flat foot is the compensation of the forefoot
yeah.
into either a reducible inverted posture or fixed. So, I'm not going to change yet, but
No,
I think it's going to be hard.
I'm still using plaster of Paris, and I still will be for the future until because for those exact reasons. So obviously we have clinicians and we have patients or the public listen to the podcast. So we spoke about tips for podiatrists who may haven't used the Richie Brace and want to know more. What about, say, if we've got a non-medical, a non-podiatrist person listening, and they may have some ankle arthritis or whatnot, or a adult acquired flat foot, and they're thinking, actually, I've tried different things in the past. This may be helpful. What would be your advice to those people listening?
Again, I think it's difficult because there are a subject few clinicians in the UK that currently offer the Richie Brace. And, actively, both you and I are trying to increase that number.
Yeah.
And I think at some stage, what I'd really like to see is this is the list of clinicians that you can go to within your postcode that offer the Richie Brace. Now we have patients traveling from, as you do, and I know that you treat internationally as
Yeah.
well. It is a minority. This isn't a treatment that's offered in a run-of-the-mill clinic. That's the reality of
Yeah.
this. I think again, Google is a great source, and simply putting in podiatrists and Richie Brace in the UK, you are then going to pinpoint clinics that actually offer that as a treatment option. Again, both you and myself, we do talk about it quite a lot. I probably talk about it a bit more. So I think it's difficult. What if I was a patient looking for a specific treatment? I don't think I would be concerned over how local that might be if there's a specific
Hmm.
professional who has had more experience. I think the thing is with the Richie Brace, it is having that exposure to patients that, like you and I, and there isn't a lot of evidence base on Richie Brace, unfortunately, again, which needs to be better. But I guess that I don't know whether you've got anything more to add to that.
No, the only because obviously if they're based in the south, I can help out. Based up the north, then you can help out. And there are
Yeah.
different clinics in the middle that I know Trevor Pryor in London does them as well.
Liam
Um,
McManus in London.
yeah, in London he does them. But in the past, patients have found me from contacting Firefly, and
Yeah,
Firefly they know which clinicians, which areas. They can always help signpost you to geographically what's the most convenient if that's a concern for you. That'd be
absolutely.
my only bit of advice. So looking
Hmm.
to bring this to a close now, you mentioned something about education for fellow podiatrists and a course, and I believe you have something coming up soon. You've run it once already. You're running it again, aren't you?
Yeah, so basically, last year, our first cohort of an introduction to prescribing the Richie Brace ran, and essentially we do a 2 day course, which is a day of theory where we have expert leaders in adult acquired flat foot, both from surgical backgrounds. We also have Dr. Doug Ritchie presenting. Very lucky to have him presenting. He joins us from California at about 7 in the morning to come and deliver a live lecture with a Q&A session afterwards. So absolutely fantastic. We then move to the practice where we work on assessment-based presentation, rehabilitation, footwear choice, and then we get everybody on the course to do a cast. And we talk through the methods of casting, what makes a good cast, what makes a bad cast, and really kind of putting into practice how we create a cast. Then following the course, we do webinar series of a couple of hours, and we bring everybody from the course and kind of help them implement it into
Yeah.
their personal space. So we're running this course in 2024 on the 30th and 31st of March. And we have just opened up our applications for that. So actually launched that just this week, and we've had
Yeah.
a great amount of interest. We are limited on numbers, so I don't know how many will be booked by the time we launch this, but we're also looking at a second date for that as well. So great.
So to sum up, it's 2 days,
Mhm.
and the first day's theory based around about prescribing, getting a presentation from Doug, I think yourself speaking, and
Yeah,
Martin also from
Martin as well.
Firefly,
Yeah.
and George, podiatric surgeon, I believe, is speaking. And then the second day is all about, okay, you've got the theory, but now what's the practical element? How to physically take the cast. And then it sounds like there's some help and support after. So you've got that complete package of knowing the theory, doing it, and then supporting you so you can keep using it in practice. Well, I say if you send over the link, we will put the link in the show notes for this. So if you are a podiatrist listening, I think it's a fantastic thing. If you're not using Richie Braces in clinic and want to, then well, it's the only course I'm aware of that's ever actually run. And I've been practicing since 2009. If there have been other courses, I haven't been aware of them. But yeah, I think it should be a fantastic couple of days. I think that's a nice place to bring this to a close now, and just want to say a massive thank you for taking time out of your evening to come and have a chat. So thank you very much, Zoe, for coming on
Not at
board.
all. Anytime. Pleased to do it.
So hopefully you enjoyed that episode. We'll put links to Zoe's clinic and the course in the show notes. Please do subscribe to the podcast, and we really look forward to seeing you on the next episode. See you later. Bye.